Think of this as a rapid-fire medical ward round. Our roadmap takes us chronologically through normal anatomy and descent, the roadblocks of undescended testes, the classic torsion versus infection dilemma, hydrocele, varicocele, and finally, we'll look at the ultimate threat, Fournier's gangrene.
First up, anatomy and the great descent.
Now, what's totally fascinating about our baseline anatomy here is that it begins nowhere near the scrotum. It starts way up in the retroperitoneum. From day one, these organs are essentially programmed for a massive anatomical migration. Just look at this timeline. At 3 months of intrauterine life, they're sitting high up. Then, driven mostly by the differential growth of the abdominal wall, they start moving. By 6 months, they hit the iliac fossa. 8 months, they reach the superficial ring. And right at the buzzer, at 9 months, they finally drop into the scrotum. It's a 9-month high-stakes journey where the left side actually usually beats the right side to the finish line. And because they start so high up, they literally drag their original blood supply and lymphatic drainage down with them from the abdominal aorta. This creates a really interesting natural dichotomy. The left and right sides, they're actually fundamentally different when it comes to plumbing. The right testicular vein drains straight into the inferior vena cava, and its length goes to the aortopalval nodes. Pretty straightforward. But the left testicular vein, it has this much longer course, and it has to drain at a strict right angle into the left renal vein, sending its lymph to the para-aortic nodes. This asymmetrical setup is a huge deal, and it's going to have major clinical implications later on. Moving on to section 2, undescended testes, or what happens when that journey goes missing. So what happens when that crucial 9-month timeline gets interrupted, especially on that slower-moving right side? Well, you get cryptorchidism. That's when the testis simply gets arrested somewhere along its normal path of descent, most commonly getting stuck right in the inguinal canal. Now, you got to differentiate this from an ectopic testis. An ectopic testis deviates from the normal path entirely. It's off-roading, usually ending up in the superficial inguinal pouch. If the testis is completely MIA and hidden in the abdomen, diagnostic laparoscopy becomes your absolute best tool to go track it down. Normally, we give it about 4 to 5 months for spontaneous descent. But if surgery is needed between the 6 to 12-month mark, surgeons run into a huge problem. The testicular vessels are just too short to reach the scrotum. So they might use what's called the Stephen Fowler 2-stage technique. And honestly, stage 1 sounds a little crazy. They do a high ligation. They physically cut those short main testicular vessels just to free up length. So how on earth does it survive? Because it brilliantly relies on a backup dual blood supply from the cremasteric vessels. Then, weeks later in stage 2, they take that now mobilized testis and bring it down safely into the scrotum. The big takeaway here is that retention is dangerous. You absolutely must fix it. Just use the mnemonic testis to remember all the catastrophic complications of leaving it undescended. They are incredibly prone to torsion, epididymal orchiditis, sterility if it's bilateral, and trauma. But pay special attention to the eye. An indirect inguinal hernia is actually the most common complication because that patent processus vaginalis is pulled right down with it. And then S for seminoma. We are talking about a cancer risk that is 6 to 9 times higher. And bringing the testis down surgically, it doesn't eliminate the risk, it just makes the cancer way easier to monitor.
All right, section 3, torsion versus infection. And for this one, the clock is absolutely ticking.
That very first complication we mentioned, torsion, it creates an absolute nightmare scenario in the ER. You've got a patient in agonizing pain, and you have to decide right now if it's a structural disaster or just an infection. The main culprit behind torsion is a congenital defect we call the Bell-Clapper testis. Normally, the tunica vaginalis firmly anchors everything down. But with a bell clapper, there's an unusually high investment of this covering. So just like a clapper swinging freely inside a temple bell, this anatomical cork allows the testis to rotate on its cord, inevitably twisting and totally cutting off its own blood supply. Picture this. An eager intern wakes you up at 4 a.m. with a young patient in acute sleep-disrupting scrotal pain. You have got to use this rule of threes to instantly figure out if you're dealing with torsion, which is a surgical emergency, or epididymorchitis, which just needs antibiotics. First, lift the testes. If the pain goes down, that's Prensign for infection. If the pain spikes, suspect torsion. Next, look at the level. Deming's sign shows a torsed testis riding abnormally high because that cord is all twisted up. Finally, Angel's sign reveals a testes lying completely transversely instead of its normal vertical orientation.
This brings us to one of the most vital rules in emergency surgery. Torsion is a clinical diagnosis. Do not, I repeat, do not sit around waiting for a Doppler ultrasound if your clinical exam points to torsion. The clock is relentlessly ticking. You've only got about 6 to 8 hours of viability before irreversible necrosis sets in. You must push for immediate scrotal exploration.
Once you get into the R, if you beat the clock and you're within that golden 6 to 8 hour window, you untwist it, wait for the color to return, and you save the testis. If you're too late, you have to do an orchiectomy and remove it. But here is the golden rule. No matter what happens, viable or non-viable, you absolutely must perform a prophylactic or chiropexy on the contralateral side. You stitch the other, healthy side in place with a 3-point fixation. Why? Because that bell clapper deformity is almost always bilateral, and you cannot let a repeat disaster happen. Section 4, hydroceles. We're talking balloons of fluid now.
So let's look at what happens when that tunica vaginalis, that protective double-layered sac, fills up with excess fluid instead of twisting. This is a hydrocele, and it generally comes in 2 distinct flavors. First, a primary vaginal hydrocele. This is a tense swelling caused by defective fluid absorption. Because it's filled with clear fluid, the testicle is hidden away and not separately palpable. But if you turn off the lights and use a simple pocket torch, it brilliantly transilluminates. A secondary vaginal hydrocele, on the other hand, is lax. It's an oversecretion issue caused by trauma, a tumor, or infection. Because that fluid is turbid and cloudy, you can usually feel the testis, but you won't get any transillumination.
If you really want to conceptualize the physical exam of a hydrocele, think of a massive hot air balloon, or even just a simple water balloon. Because it's a perfectly enclosed sac of fluid, it demonstrates this classic clinical sign of fluctuation. If you press firmly on one side of the swelling, the fluid gets displaced, and the other side immediately bulges out. It's literally a perfect closed hydraulic system. Let's dive into Section 5, varicocele, affectionately known as the bag of worms. We're transitioning here from trapped fluid to trapped blood. A varicocele is essentially dilated, tortuous veins of the pampiniform plexus, and it is a massive cause of male infertility because it wrecks the natural countercurrent heat exchange mechanism, raises local temperatures, and halts spermatogenesis. Remember how we said the left side is wildly more common for issues? Well, our baseline anatomy explains exactly why. There are 4 major anatomical traps hampering the left side. First, the left vein is just physically longer. Second, it fights gravity to drain at a sharp right angle into the left renal vein. Third, a loaded sigmoid colon can physically compress it. And fourth, this one's crazy. The left adrenal vein dumps vasoconstricting catecholamines directly opposite its opening, literally clamping down on the blood flow.
Clinically, when you examine it, a varicocele feels exactly like a bag of worms inside the scrotum. But listen up, because here is a massive red flag you simply cannot ignore. If an older patient walks in with a sudden, recent onset left-sided varicocele, you must immediately check their abdomen. Why? Because renal cell carcinoma is notorious for growing a tumor thrombus right down the left renal vein. If that tumor blocks the opening where the testicular vein drains, it creates a rapid secondary varicocele. Do not miss a kidney tumor just because you were too focused on the scrotum. And finally, Section 6, Fournier's gangrene, the ultimate threat. We have reached the most devastating pathology in this entire explainer. Fournier's gangrene is a rapidly spreading polymicrobial synergistic necrotizing fasciitis of the perineum. It almost always targets immunocompromised or diabetic patients, and the scary part is it's often triggered by something completely trivial, like a routine catheterization or just a tiny scratch. It presents with an overwhelmingly foul smell and throws the patient into rapid septic shock. The only way, literally the only way to save the patient's life is immediate, aggressive, and absolutely ruthless surgical debridement of all the dead and dying tissue alongside heavy IV antibiotics. But here is when we bring this whole explainer full circle. There's a very visceral quote from the iconic medical textbook Bailey and Love that notes after this massive, destructive debridement, the testes are usually left perfectly fine. How is that even possible? Well, remember our first segment? Because they drag their own separate, dual blood supply all the way down from the aorta during their long embryonic descent, they don't rely on the local scrotal blood supply that was just destroyed by the gangrene. They miraculously survive the necrosis, even as everything else around them is completely stripped away. And honestly, that perfectly illustrates a true biological paradox. How can an anatomical structure so small possess such intense, life-saving engineering in its blood supply, yet carry so many dramatic, catastrophic vulnerabilities, from torsion to varicoceles to hernias? It's a total marvel of both jeopardy and resilience. I really hope this fast-paced explainer helps you decode the mysteries of testicular pathology, from embryology all the way to the emergency room, the next time you hit the clinical wards. Thanks for joining me on this deep dive.